Scoliosis is a complex condition with several different causes or etiologies, and each of these causes presents their own unique challenges. Hey, I'm Dr. Jules from Scoliosis Denver, and in this video, I'm going to dive into the different types of scoliosis to help you better understand exactly what scoliosis is and what causes, because depending on the cause, that frequently determines how we properly treat it. So first of all, let's actually go over what scoliosis is and how we define scoliosis. Scoliosis is actually defined or diagnosed when we have 10 degrees of lateral bending with rotation present on an x-ray. Those are the two criteria we need, and scoliosis is actually diagnosed when viewed on an x-ray. A lot of times we do other testing to help us identify that scoliosis may be present, but x-rays is the gold standard to actually rule in or rule out. So again, we have to have at least 10 degrees of lateral bending with rotation present on an x-ray to actually diagnose someone with scoliosis. Now, one of the ways we classify scoliosis is based on the age. So we would say someone has infantile scoliosis if they are diagnosed with scoliosis when they're between the ages of 0 and up to 3 years old. We would say someone has juvenile scoliosis when they're diagnosed between the ages of 4 and 10. Now, both infantile and juvenile are also known as early onset scoliosis. And this is important to know because the earlier scoliosis develops, the higher risk of curve progression. So infantile scoliosis and juvenile onset scoliosis have a higher risk of progression to surgical levels, and they're generally more aggressive. Now, adolescent idiopathic scoliosis is scoliosis that actually develops during growth spurts, typically between the ages of 10 and 18 years old, or up till skeletal maturity. And adolescent idiopathic scoliosis is the most common age range where scoliosis is developed for idiopathic scoliosis. And then we have adult scoliosis. Now, scoliosis in adults could be due to a scoliosis they had when they were younger and they still have as an adult, which is basically an adolescent scoliosis present in adulthood, or they could have a new scoliosis that actually develops in adulthood, which is known as adult de novo degenerative scoliosis. Now, one of the things that adults could have is you could have scoliosis in adults where it's actually present due to some other secondary conditions that we're going to talk about later on in the video. So those are the 4 different classifications. So of those, which do you think is the most common? You think it's infantile, juvenile, adolescent, or adulthood? When we look at these, it's about 0.3 to 0.5%, so less than 1% of infants or children are diagnosed with scoliosis. When we look at up to the age of 18, we start looking at adolescents. It's about 2 to 4% of adolescents, or some studies say 5% of adolescents are diagnosed with scoliosis. When we see people that are 40 years old, it's about 9% of 40-year-olds are diagnosed with scoliosis. And then when we look at 60 years old, this is where it gets much bigger. So 35% of adults over the age of 60 get diagnosed with scoliosis, and anywhere between 50 to 68% of adults over 90. So we know that scoliosis is much more present in adulthood than it is in children, which a lot of times is counterintuitive because a lot of people think about scoliosis in adolescence. They may not think about it as much in adults, but scoliosis in adults is actually the biggest problem we see in healthcare. Another thing we want to think about is why do we really see the increase around 9 to 10% in young adults? Well, typically when we're seeing young adults that have a higher percentage, it's because we have adults that have scoliosis when they're younger, where it doesn't really get picked up or diagnosed, and then it becomes more painful, or they go to the doctor for something, they get an x-ray, and they get told they have scoliosis. So most of these 40-year-olds that have scoliosis, they actually had it when they were younger. It was just never picked up or diagnosed. But we see a huge intake in older adults, especially in women after menopause. That's when we see an increase. It's also where we see curves progress more in adulthood and where some scoliosis starts, which I'll cover a little bit later. The other way we can classify scoliosis is based on severity. So if a curve is less than 25 degrees, it's typically considered a mild scoliosis. Scoliosis between 25 and 40 is considered moderate, and anything over 40 is considered severe. Now, just because a curve is mild or moderate based on the size of the curve, that doesn't mean the curve is not a serious condition and doesn't have a high risk of progression. Because the other thing we have to look at when we're looking at scoliosis and we're determining the risk of progression, one of those things is size, but also the age of the patient. Meaning, if you have a 25-degree scoliosis in someone that is 16 or 17 years old and they're about done growing, that is not a huge concern or risk of progression to surgical levels. However, if you have a 25 degree curve, and let's say a juvenile, that's someone that's like 7, 8 years old, or when you have someone that is, say, a girl that's 10 or a boy that's 12, and they still have a ton of risk of growth left, that is considered a more aggressive scoliosis, so we have to treat it appropriately. We do look at size of curve when we're looking at what's the most appropriate treatment, but even more importantly is what is the risk of curve progression. So smaller curves and people that have a lot of growth can still have a high risk of progression. But severity below 25 is considered mild in degrees, 25 to 40 moderate, and above 40 severe. Now, what actually causes scoliosis? 80% of all scoliosis is actually considered idiopathic. Idiopathic is just a big fancy word which means no known cause. But I'm going to explain in detail what actually happens. So when we have idiopathic scoliosis, we know there's a genetic component. And there's something that triggers the genes where part of the vertebrae grows faster and part of the vertebrae grows slower. There's actually several different growth plates within a vertebral body or a vertebrae, which is the bones of the spine. And some genes get triggered where some of the bones grow slower and some of the bones grow faster. When that happens, the spine starts to twist and rotate. Now, what exactly triggers that? It's probably multifactorial and there's different theories. Some people actually believe it's due to hormone changes. It could be due to asymmetrical growth or asymmetries in the body. It could possibly some muscular imbalances. And like I said, genetic factors. So it's likely multifactorial. Now, what actually happens in this phase right here, the spine actually takes off and grows really severe. So right around puberty during growth spurts, this is when the majority of growth actually happens. And the reason being is before puberty during childhood, the majority of your growth actually comes from your limbs, your arms and your legs, about 2/3. Right around the onset of puberty though, that changes where the majority of your growth actually comes from the spine. You grow really fast the first 5 years of age. Actually, year 1 is the fastest, year 2, 3, 4, 5, it slowly decreases when we look at the rate of growth. Then from about 5 till 10 or when puberty starts, the growth is actually pretty steady. But right at puberty, especially the first 2 years, typically between 10 and 12 in girls and between 13 and 14 in boys, those first 2 years, your rate of growth really takes off. This is called your peak height velocity, your peak growth velocity, where you grow the fastest outside of those first 5 years of life. And it's during this time that scoliosis tends to progress very rapidly right here. Puberty typically lasts around 4 years, is different, but those first 2 years are the most fast when curves can progress the most rapid. Now, the second part of growth, where you're actually deaccelerating the rate of growth, you continually shift the proportion of growth to your spine. So during this phase right here, and this is the graph actually created by Dr. Tony Nalda that actually shows the rate of curve progression over time. And it's right here during puberty where these curves really take off, and especially those first 2 years. Now, once someone is done growing, some people actually believe your curve does not have a risk of progression. But we know that's absolutely not true. We know that curves over 30 degrees have an increased chance of progressing, and curves over 50 degrees will 100% progress. But the size of the curve is not the only thing we look at. We also look at the location. For example, when we look at curves in the thoracic spine, they have a smaller chance or are less likely to progress rapidly than curves in the thoracolumbar or lumbar spine once someone is done growing. Some other things we want to look at is things like osteoporosis or other metabolic conditions that can increase the rate of growth later on in life. We look at, does someone have an anatomical short leg? Is one leg shorter causing the pelvic to tilt? Do they have a coronal imbalance? Are they shifted off to one side? Do they have a decreased curve in their lumbar spine, or is the curve in their spine from the side smaller than it should be? Do they have some instabilities in their spine, like a lateral listhesis where the bone is slipping off the vertebrae? Those are a few things that we actually look at. And then when we look at this, once we get to like 18, the rate of growth is pretty slow until around 40 when the rate actually starts to pick up and increase. And then later on, especially in women right around menopause, that's when curve progression accelerates. That's also in here when those degenerative de novo scoliosis typically starts. And then later on in the life, it just gets faster and faster. So the rate of growth in adolescence is really faster in puberty, especially those first 2 years. But also we have an acceleration in growth, which is more of a degenerative process later on in life, especially after 50 in women. And then as men get older, it tends to progress more and more severe. Also, the more severe the curves, the faster or the higher risk of progression in these phases after adulthood. Now, let me show you what actually happens. So as I mentioned, we have this genetic condition and we have some initial event that triggers the spine to start to actually grow asymmetrical and twist, whether that's biomechanical or hormonal or neurological event. Something, and it's probably multi-factor, something happens that causes the vertebrae to grow asymmetrical, and that causes the spine to start to twist and rotate. And you start to get some wedging in the disc and the vertebrae, and you get some compensations in the spine, and you get this curve developing right here. Now, what's interesting, once the curve gets beyond about 20 degrees, something else takes over. This is what we're talking about in the growing spine right here. And when you have a curve like this, when you have a curve, you have more pressure on the inside of the spine and vertebrae and less pressure on the outside. So in a curve like this, there's more pressure on the inside of the spine and the disc, and the outside is actually almost being pulled and tractioned. The reason why this is important is there's a principle called the Hooter-Volkmann principle. And the Hooter-Volkmann principle or law actually states when you put pressure on bone, you actually slow the rate of growth. So when the bones are still growing and the growth plates are open, when you put pressure on those bones, you decrease the rate of the growth. And when you put traction or you pull on the bone, you can actually accelerate the rate of growth. And so now you have a second mechanism that starts to kick in addition to this initial genetic and other multifactorial thing. So something genetically starts this, but when the curve gets beyond 20 degrees, we have this mechanical force on the inside of the curve where the Hooter-Volkmann principle takes over, and the inside of the curve, the bones are growing slower and the outside is growing faster. This typically happens when the curves get about 20 degrees. One of my friends, Dr. Jean from Scoliosis Care, says it's the difference between a Toyota and the Subaru. The difference is the Subaru has turbo booster in it, meaning once the curve gets beyond 20 degrees, you have more mechanical pressure on the inside, and that's like a turbo increasing the rate of curve progression. So then you get this asymmetrical growth that grows faster and faster. That's this Hooter-Volkmann principle. So I talked about the bones growing asymmetrical. This is what's happening. You can see the inside of the curve is growing slower, the vertebrae, the outside is growing faster, and the bone is growing asymmetrical. As the spine twists and rotates, that causes a rib humping in the thoracic spine or also humping in the lumbar spine. So the vertebrae is rotating up, and that's where that humping comes from. But the key here is to understand the spine is growing asymmetrical. And it's growing asymmetrical at an accelerated rate in larger curves because asymmetrical pressures on the spine. It's important to understand this because if you understand why the spine is doing what it's doing, you understand how we go about treating it and why some treatments work and why some treatments don't. This really shows what's happening on the vertebrae. You have the rotation happening, which causes the rib humping. The spine rotates, which causes rib humping. You can see the vertebrae is deformed in here. So this is going to be the side that has more pressure. This has less pressure, so the spine is twisting and rotating and causing that humping. It's important you understand this because, as I mentioned, when the curve gets beyond 20 degrees, then you have bigger asymmetrical pressures, which accelerates the growth. So if you understand why this grows faster, especially in larger curves, you understand how we treat it and why some treatments work and some treatments don't. So we get this asymmetrical loading and we get this rotational deformity. I mentioned Hooter-Volkmann principle. As you get a bend in here, you start to get more pressure on the inside and less on the outside. And that's what actually causes the wedging, where the inside of the vertebrae are growing slower, the outside is growing faster, and the same thing actually happens in the disc. And that's when we start to see this wedging deformity on the vertebrae like this. By the time you get that wedging deformity, it's a pretty severe curve. But this right here is a severe curve. The key takeaway is all true scoliosis eventually develops into deformity. And the earlier we can get on top of these deformities, the better we can treat them and the better we can actually control their growth over time. And the earlier we identify scoliosis and the faster we treat it, the better outcomes we can get, because all big curves start off as small curves. When we treat curves when they're smaller, it's easier and the treatments are more effective. when we treat curves or start treating curves and they're larger, we're already behind the 8 ball a little bit and we're chasing that scoliosis and we're really just trying to put the brakes on. So the earlier we catch it, the smaller the deformity, the better chance the most appropriate treatments have at effectively treating scoliosis. When we look at this, when curves get beyond 30 degrees, they have an increased chance of curves progressing. When they get beyond 50 degrees, it's pretty much a consensus in the scientific world that they will 100% continue to progress. Beyond 30, they also have an increased chance of causing other health problems and reducing quality of life. Beyond 50, they most certainly are going to have an impact on overall health, and it's also going to cause a decreased quality of life. And especially when you get those larger curves, it starts to cause disability, which means the scoliosis frequently becomes painful. It inhibits someone's ability to do their normal daily activities. Now, if you're watching this and you have scoliosis, or you have a family member or a child that has scoliosis, I'm going to encourage you to click on the link below and request a free discovery call. A discovery call is a chance to talk to me about your individual case for about 15 minutes. We can go over your curve, the severity of your curve, the risk of your curve progressing, and the treatments that you're most likely to be a candidate for. So click on that box below, request a free discovery call, and my team will reach out to you to get that set up. Now, we went over idiopathic scoliosis, which is 80% of all scoliosis. But what about the other 20%? What else causes scoliosis? Now, one common cause of scoliosis is what's known as congenital scoliosis. A congenital scoliosis is something you're born with, and there's some different types of congenital scoliosis. One of those is where you actually have a wedged vertebrae or a hemivertebrae, which is a failure of a vertebrae to completely form, like we see here. You can also have vertebrae that are blocked or linked on one side. So here you have several vertebrae that are connected, then the outside's not. And then you have a whole other section of blocked vertebrae. So you have a failure or separation. This is what a congenital scoliosis actually looks like on an x-ray. And these frequently end up needing surgery. Sometimes there's conservative treatments we can do to work on the areas above and below, but a lot of times these scoliosis are actually going to require surgery. And then there's neuromuscular scoliosis. These are secondary to some neuromuscular condition. Some types of neuromuscular scoliosis are cerebral palsy and also muscular dystrophy. These, a lot of times what's happening in these two is the individual is unable to hold themselves upright, and so they start to collapse. And when they collapse, they get asymmetrical loading, and that asymmetrical loading causes the spine to deform. Some other neuromuscular scoliosis could be neuromuscular fibromatosis, for example. It's another common one that we see in our practice. And then we have like pathologies. Probably the biggest one I think of this, there's like tumors, and then something called like a syrinx or a fluid-filled cyst on the spinal cord. There's something that is pushing on the scoliosis that's driving that. And these can be hard to detect. So there are certain things we look for, or red flags, that tell us that there could be an underlying pathology. One of those, if you have a left thoracic scoliosis, some red flags we look for that tell us there could be something pushing on the spine or spinal cord causing the scoliosis include like left thoracic scoliosis. That's a red flag telling us there could be something else going on. Right lumbar scoliosis is a red flag. It tells us there could be some other pathology. And when I say red flag, that means that something gets our attention, that it's a bit abnormal, right? And there may be something else driving the scoliosis other than just a congenital condition. Another one could be, a lot of times when you get a thoracic scoliosis, we typically see a decrease in the curve from the side, or what we call flat back syndrome, or a hypokyphosis, a decrease in this curve. If we have a scoliosis in the thoracic spine, and there's also hyperkyphosis, that gets our attention. We don't typically see that. In boys, especially in adolescence, boys have a higher rate of pathologies than girls. So boys gets our attention. It's something we definitely want to check, make sure we're ruling those things out. And then any abnormal neurological testing, especially if someone has a decrease or absent abdominal reflexes. But basically do a whole bunch of neurological tests to tell us is there anything else that could be a potential sign. If you have increased pain at night, that's a potential red flag telling us, there could be something like cancer or underlying condition. If you have a lot of pain or tenderness on certain vertebrae with palpation, that should get a provider's attention. So there's a bunch of things we do when we do an exam to rule in or rule out. And by the way, if someone is treating scoliosis, they're responsible for all the potential causes and to rule those or rule out, which is also why you got to go to a true specialist. We've had patients come into our office that have been to the local hospital, been to the orthopedic specialist, actually been treated on those, and we found an underlying pathology which was the actual driver of the scoliosis, and it was missed by the so-called experts that they were going to. So you always got to check those things in detail. And then there could be scoliosis secondary to connective tissue disorders like Marfan's or Ehlers-Danlos. These are connective tissue disorders. People have hypermobility, and a lot of times their body doesn't hold themselves upright and they can actually collapse. And then one of the last ones I'm going to talk about is trauma. You could have scoliosis that is secondary to a trauma. So I hope you found this information really helpful, and that should give you some better ideas of what causes scoliosis. And if you think you may have scoliosis or you suspect it, that's where you go to our next video. In this next video, I go over 7 signs to look for to identify scoliosis. So click on the next video and I'll see you there.